In the last video, I showed you the 3 moments in an unfolding case study where clinical judgment gets built or bypassed before any data is revealed at the decision point and in the debrief. In this one, I want to show you what the right questions actually sound like in those moments, because there's a version of Socratic questioning most faculty use and a version that actually builds clinical judgment. And the difference is easy to miss until you've seen them both in the same room. It comes down to one thing. Are your questions evaluative or developmental? Here's the difference. The evaluative version asks questions to find out whether the student knows the answer. Is this blood pressure normal? What does tachycardia indicate? What should you do first? Each one has a correct response already sitting in the faculty member's head. The student either produces it or doesn't. The question is a probe. The developmental version asks questions to activate and extend the student's reasoning. Hear the difference. His blood pressure was 128/78 at admission. It's 104/68 now. What does the direction tell you that the number alone doesn't? Or, you gave me a list of abnormal findings. Which one concerns you most? And what makes you rank it first? Or, you're not certain anything's wrong. What would you say if you called the physician right now? Those can't be answered by retrieval. They require integration, reasoning across several pieces of information in real time out loud. And here's the part that changes the room. When a student gives a wrong answer and you respond not with correction, but with curiosity, I can see why you'd think that. Tell me more about the reasoning that got you there. Something shifts. Students stop performing and start thinking. They start exposing their uncertainty instead of hiding it. And that exposed uncertainty, met with genuine curiosity instead of a red pen, is the single most productive raw material you have for building clinical judgment. Because the student who can say, I'm not sure, but something feels off, in your classroom is practicing the exact behavior that will keep a patient alive at the bedside. Let me make this concrete. Picture a 54-year-old post-surgical patient with obstructive sleep apnea on a hydromorphone PCA. Before you reveal a single vital sign, you ask, what is this patient's biggest risk right now? Students taught to think in frameworks will name it immediately. Opioid-induced respiratory depression. Good. Now the harder question. What's the earliest sign that risk is becoming real? Not the apnea, not the cyanosis. It's the respiratory rate beginning to drift down. 2 or 3 hours before anything becomes undeniable. That one pre-brief question does something the case itself never can. It makes students surveillance-minded before they ever walk in the room. It builds the anticipatory thinking that separates a practice-ready nurse from one who's waiting for the monitor to alarm. Now the decision point. It's 2300. Respiratory rate was 14. SpO2 is 95%. The patient's increasingly drowsy, hitting the PCA button often. You stop and ask, based only on this, what's your clinical judgment? Stable or unstable? And what single data point would change your answer? Most students will say the SpO2 is fine. Some will catch the trend, but very few, without prompting, will name the thing that matters most. The supplemental oxygen can mask hypoventilation. It props up the number while the patient is quietly underbreathing. And that is the teaching moment. Not at 0300 when the crisis arrives. Now, in the ambiguous middle, while the window is still open and everything is still preventable. So here's the whole thing in one line. The case is the vehicle. The questions are the engine. We've done real work this past decade, unfolding case studies, judgment frameworks, next generation NCLEX. It matters. But new graduates still struggle most with recognizing what's clinically significant and acting on it. And that gap isn't in the cases. It's what we do with them. The pre-brief question, the developmental question at the decision point, the debrief that names the rescue window. Those aren't techniques to bolt on. They're how you build the cognitive habit a nurse carries to every patient they'll ever care for. So, are your students learning to find the right answer or to recognize when something's wrong before the answer is obvious? Come see what that looks like at lifebeatsolutions.com. Thanks for watching.